future in our hands, because that's a big responsibility on our part, right? This is not just about what you can give us, it's what we can give back to you. And then that moves into surgery. Okay, so the surgical services here are growing very quickly as our hospital is growing, and that's a good thing, right? Because that means that our cardiac surgery service is growing. We have a robust program now with record high numbers of cardiac cases and ECMO cases. We have a very active orthopedic surgery department that takes on challenging skeletal problems on a daily basis. Our ENT service is very, very busy. There's a long waiting list, and we continue to add otolaryngologists to our staff. Our neurosurgeons are constantly pushing the envelope in their field. Our urologists are also developing new services, and we have more urologists joining us later this year. Then we have the general surgeons, which is what I do. We continue to give compassionate care to our neonates and our oncology patients. And then all of our teams strive to stay on the cutting edge for minimally invasive surgery. In the future, we are planning on having a transplantation of the lung program and a liver transplant program. And additionally, we plan on adding trauma to our services. So it's very likely, and I can almost guarantee it, that during your employment here, you will be taking care of surgery patients. And that's why this surgical nursing series is so important to everyone's success, because we all know that you are the ones that are at the forefront of patient care, and without an excellent nursing staff, none of this can happen. None of us can be successful. You can be the best surgeon in the world, but if you don't have strong nursing, it just ain't going to happen. So this is why I'm here to spend my time with you, because I value what you do. And having been a patient once before too, I really value all the loving care that you give your patients. So again, I thank you for coming to us. Okay, so one of the major topics, or one of the major obsessions, I should say, that a surgeon has in a perioperative patient is the fluid management. And this is because there are so many imbalances that we see in the fluid of our patients. They can come in with fluid derangements. They develop fluid derangements in the hospital with what we do to them. And then we have to put it all together to make sure that we have homeostasis so that the patient can perfuse properly, perfuse organs, and not go into shock. So many of our patients, our kids, will come in dehydrated from various conditions, one of them being abdominal pain. They're anorexic, they won't eat, they don't drink, they have vomiting, they're losing fluid from there. We have patients come in with appendicitis who are vomiting, patients with pyloric stenosis who are vomiting, and they're already coming to us behind the 8 ball in terms of their fluid management. Then we have the children who come in with diarrhea, inflammatory bowel disease, for instance. We have patients with intussusception who have had diarrhea before the intussusception. These are all things that we have to think about when the patient comes to us. And we take a good history, because this is where we get that information from the history. A good history to help us assess the patient's fluid status. And then there's our coming in bleeding. We have our trauma patients that come in bleeding. We have patients with upper gastrointestinal bleeds, patients with lower intestinal bleeds, and that also compounds the problem of fluid imbalance. And to make matters worse, then we take them to the operating room, right? And then we cut them open, they bleed, they lose third-space fluid. On top of already what they have is a fluid deficit. And then we make them NPO, right? We don't feed them. So with all of these fluid imbalances, you can understand why the surgeon is so obsessed with knowing that the patient's peeing. The patient has a normal urine output. The patient has normal heart rate, right? Because we understand that all along the way, all along this patient's course, along this path, there have been fluid losses that we may have or may have not have replaced. So, how do we treat the patient? What do we do next? What are the parameters that we look at to determine how much fluid we give and what kind of fluid we give? This is the point of this lecture, to try to get you to understand how the surgeons think about fluids in their patients, so that you can help us, as you monitor the patient, you can help us make the right plans for the fluid management in our patients. Okay, to understand perioperative fluid management, you have to understand basically three things. Maintenance fluids, what do we all need on a daily basis just to be in homeostasis? What are the fluid deficits that the patient is coming to us with? And what are the ongoing losses that we see in the patients throughout the hospital course? We're mostly made of water, right? Everyone learns that in their biology classes. But neonates have more water than adults. Neonates, their body is comprised of 70 to 80% water, as opposed to the 1-year-old that has 60% of body weight made from water, and that's the same amount of percentage of body water that persists throughout life. That's the adult equivalent. Do I have a pointer here? Yes, I do. Okay. So we have two major body compartments of water in our body, right? There's the intracellular fluid compartment and the extracellular fluid compartment. The cell membrane separates intracellular fluid and extracellular fluid. 40% of our body weight of the water is in the intracellular compartment, and then 20% of our body weight is extracellular fluid. The extracellular fluid compartment is broken up into two further compartments where you have plasma, which is basically intravascular, that's 20% of your body weight, and then 20% of this 20%, forgive me, and 80% of the extracellular fluid is in the interstitial fluid. Throughout the patient's surgical course, and you may see this also with medical conditions, patients who have SIRS, that have bad inflammatory responses to medical conditions, the fluid is going to go back and forth between these spaces. Okay? If you're bleeding, you're going to lose from the plasma. If you have SIRS or edema, you're going to have leaky capillary walls, and fluid is going to go from the plasma into the interstitial fluid. And then if there isn't enough fluid, what happens? Intracellular fluid then leaches out into the interstitial fluid, which then can cause problems with your metabolic functions within the cell. Okay, so all of this is dynamic in all our patients, particularly surgery patients, but not just surgery patients. There are other patients who are septic and have medical diseases that have this phenomena as well. So let's talk about normal body fluid losses, because that's important to know how to get homeostasis, right? Our metabolic processes involve use of water. If you look at the Krebs cycle and all the other biochemical cycles, you'll see that water is pulled in to those chemical reactions in order to make our engine go. We have insensible losses from the skin and from the lungs, and then sensible losses, which is basically our urine output, and amongst other fluids. Now this is a pretty complex slide in terms of our maintenance fluids requirements. And I'll go through this, but I'll give you also another algorithm to make it a lot easier for you to figure out how much fluid you should be giving your patient. But the point here is that the older you get, the less fluid that you'll need. Okay, so from a 3.5 to 10 kilogram infant, one would expect them to need 100 mLs per kilo per day. When they move to 11 to 20 kilograms, they'll need 1,000 mLs, so that's 10 times 100, right? Plus an additional 50 mLs for every kilogram over 10. And then when you get to the patient who's over 20 kilograms, we take the 1,500 mLs, which we took here, okay? And then add 20 mLs for every kilogram over 20 kilos to a maximum of 2,400 mLs a day. So that's the adult fluid requirement, 2,400 mLs per day. But that's pretty complicated, right? And it's real interesting because I'll have medical students that say, well, what's the IV rate? And then they'll try to calculate this whole thing on rounds when we're trying to get to the operating room. I'm like, no. There's an easier way to do this. And the easier way is the 4-2-1 rule. And I see some head shaking. You know about this. Yes, you make my... Oh, good. Because this is one of my salient points. Okay, so test them, I heard. Well, we'll review it real quick and then we're going to test you. All right, so for the first 10 kilograms, what do? Multiply by 4, okay? 4 mLs per kilo per day. And this is to give you the IV rate, hourly IV rate, correct? For the second 10 kilograms, you multiply by 2. And then for every additional kilogram, we multiply by 1. Okay, so, all right, here's your test. Calculate the IV fluid rate for a patient that's 25 kilograms. You can write down on a pen or get your calculator out. So 25 kilogram baby. So let's work through this together. Okay? So you have 4, 2, 1. All right? Are we starting because we know, or you can just tell? You want to say it all loud? 1. Okay, so do we have it? What's the number?
65.
Woohoo! Yes, you guys are higher. It is 65. 65 because, let's go through this. 65 because for the first 10 kilograms, we multiplied by 4, that's 40 mLs per kilo per hour. The second 10 kilograms, you multiply by 2, that's 20 mLs per kilo per hour, right? And then for the last 5 kilograms, you give 1 ml per kilo per hour, and then this all adds up to 65. And that's and when we have our rounds, particularly with the residents and our advanced practice providers and our students, I ask them to tell me, is the patient on maintenance fluids, half maintenance fluids, maintenance and a half? Because if they give me a number, they say, well, the patient is on 50 mLs an hour, I have to calculate, right? I have to go through my brain. Okay, well, then I need the patient's weight, right? Then I need the patient's weight, and I have to figure out, okay, the 4-2-1, what's maintenance? And I ask them not to make me work that hard. Tell me what it is. Maintenance and a half, maintenance and a quarter. And this is a very easy way for you to figure out whether your patient is getting maintenance fluids or above or below. And we'll talk about this just a little bit more because it's going to be helpful for you when you're assessing your patients to see whether they're underhydrated, adequately hydrated, or overhydrated. Okay? Okay. So, and this is the point that I was making, right? Maintenance and a half. So we know maintenance is 65 mLs per hour, but let's just say I got a kid that just came in with diarrhea and he's got sunken eyes and he's dehydrated. And I said, I'm going to give him a bolus, I'm going to give him maintenance and a half. Well, I already know what maintenance is, so all I need is another half, right? 32.7, and add that to the 65, and I've got maintenance and a half, correct? Or half maintenance. Or, like I was explaining earlier, I may find a patient who's on a certain fluid rate, and I want to calculate, well, is this maintenance and a half, or what the level is, and with the weight, I can work backwards, and I can figure out for myself what level of fluids we're delivering to the patient. All right, so I'm sure most of you know this, that what the hourly urine output is expected in a patient. And this is important for us, particularly for the surgeons, because we know that what goes in must come out, right? And if not enough is going in, not enough is going to come out, correct? And then the corollary, if we're giving too much fluid, then providing the patient has normal renal function. Now, I'm not talking about the patients in medicine who have all of the nephritides and the renal disease. Providing there's normal renal function, if you're giving too much fluid, you should be seeing a lot of urine coming out, correct? Okay. Just as the patients require less fluid as they get older, our urine output goes down as we get older. All right? Okay. Do we need to review this? Everyone understands these? And these are numbers that are very important that we should keep in our minds and memorize this, because this is something that you'll be using forever. Okay. Preoperative fluid losses can happen due to a lot of conditions. And I had listed a couple at the beginning of the talk, but you can see there are more. We have fever, sweating, burns. Patients come in edematous already due to septic processes, SIR processes. Ventilator, patients who are in the ICU that we take to the operating room on the ventilator have increased fluid insensible losses. And then patients with pleural effusions. So what are the responses that the patients have as they are losing all this fluid and not being replenished? This is going to be a busy slide, and I'm going to sit through this one because we're going to work through this, okay? Okay, I need to look at the slide. Let's just first look at the level of dehydration. We have patients that can have mild, moderate, and severe dehydration, okay? And then we have two categories here, an older child and the infant. For mild dehydration, the infant would lose about 5% of the body weight in fluid. In an older child, 3%. And then the numbers go up. For an infant with moderate dehydration, you would see a patient that has lost 10% of the fluid, an older child 6%. And then for severe dehydration, a patient would have lost 15%, and an infant, and in a child 9% of their body weight in fluid. Okay, so now that we understand the degrees of dehydration, now let's look at what do we see in patients that have the various levels of dehydration. With the patients with mild dehydration, you're going to see obviously fewer signs and symptoms. Their skin turgor may be normal. Their skin to touch would be normal. Mucosa would be dry. Eyes are not sunken yet, right? They're normal. Still making tears. He has flat fontanelle. These kids are usually alert. And the pulse rate, pulse quality, and capillary refill are normal. Notice that we don't have blood pressure here. Do you know why we don't have blood pressure on this scale? Children have a very intense sympathetic response. When they get dehydrated, they really clamp down on their blood vessels. So they get peripheral vasoconstriction, and they also get mesenteric and renal vasoconstriction. And they bring the blood centrally so that they can perfuse their heart and their brain. So they don't get the orthostatic hypotension that you would see in an adult. You're not going to see it in a kid. The unfortunate part about this, I guess it's good for the child because they can hold on longer, but what's unfortunate about this is that when you finally get a child who has hypotension, they're already in a severe state. So blood pressure will not be the tool that you will be using to catch dehydration early. It will be these other signs. Okay, let's go through the other signs here. For moderate dehydration, we'll see patient with tenting skin turgor. They have dry mucous membranes. Now their eyes are going to get a little deep set. Fewer tears. This fontanelle is now going to start feeling a bit soft. Their pulse rate is now starting to increase, and the pulse becomes a little thready, a little weak, and the capillary refill is 2 to 3 seconds. What's normal capillary refill? You just shout it out. Less than 2 seconds. Okay. And then I didn't touch upon the urine output, but this in moderate dehydration, that's when you're going to start seeing the urine output fall. Okay. The last category, severe dehydration, this is where the kids are, it's pretty noticeable. And you can just look at a child and go, he doesn't look well, she doesn't look well, because they have clammy skin. Their mucous membranes are cracked. They have sunken eyes. Their perfusion just doesn't look good. You ever hear? I'm sure you've seen and heard them say the patient looks kind of gray. Just the skin color just doesn't look good. The fontanelles now are sunken. So we started with a flat fontanelle to soft, and now they're sunken in a baby. An lethargic, obtunded child is a child that's in grave danger of going into shock, and probably maybe already in shock. Any child that you cannot arouse, or it doesn't respond the way the parents say usually does, is someone that you need to give immediate attention to. And in this situation, with severe dehydration, these children are lethargic or obtunded. Now you see the heart rate really go up. These kids are tacking away, trying to keep their cardiac output up. And the pulses are really, really feeble. Sometimes it's hard to feel those pulses. Capillary refill is greater than 3 seconds, and then the urine output is very low. And then what color does the urine output look? When a patient is dehydrated, what color do you expect? It's dark, right? Okay. So if I had to choose from this table the things to focus in on, I would recommend the following. In a baby, the fontanelle is very telltale. Okay. The mental status is also very important, especially when they become more dehydrated. The pulse rate, and the capillary refill, and the urine output. Okay, so that's what? Five things for now that we can just zoom in on, and within seconds, with a little, it doesn't take much experience, just with a little bit of experience, you can make an assessment of a patient that's severely dehydrated versus moderately versus mild dehydrated. Now I'm going to stop here and take questions about this chart, because this is really important information to relay to you. Any questions? No? Okay. All right. Well, we already talked about the peripheral vasoconstriction in patients, in pediatric patients, that don't allow them to have orthostatic changes. And I quickly mentioned the renal and mesenteric vasoconstriction, right? But this is a phenomenon that's really important to the GI doctors and the kidney doctors, okay? Because here we're operating on intestines and in kidneys. And the last thing we want to have happen to our tissues that are trying to heal postoperatively is to have poor perfusion, correct? Okay. So the general surgeons, and I'll put my pitch in as a general surgeon, that's what I do. The general surgeons, we are really focused on urine output, because we know if there's less perfusion to the kidneys, that's resulted in low urine output, then that means there's less perfusion to our intestines that's trying to heal. All right, so if we did a bowel resection and we have anastomosis that we sewed together, and these good perfusion, right? But if we come in and the patient's urine output is less than 0.5 mLs per kilo per hour, the urine is real dark, patient's heart rate is high, we get a little excited, don't we? We get a little excited because we don't want that anastomosis to fall apart and then have to take the patient to the operating room. That's where you guys come in. I could have done the most perfect anastomosis. They could have been beautiful. But if I'm not giving the child appropriate fluids post-op, if I don't know that the patient's third spacing more than I expected, right? If I don't know that the urine output is low, how do we know? How do we fix it? And that's where we depend on our wonderful nurses to keep us out of trouble, right? Like I said earlier, we can't do any of this without our great nurses. Okay, let's move on. All right, so here's another case scenario. This is a 12-year-old, 25-kilogram male with perforated appendicitis. He hasn't eaten for 3 days. He's vomited 5 times. He has loose stools, and he has a temperature of 38.5. Do you think he's going to come in with normal hydration, overhydration, or dehydration? Dehydration. Okay, so which factors here represent, or which symptoms or signs represent increased fluid losses? Okay. And fever. And fever. Especially in an infant who has more surface area to the body, so they really evaporate a lot of fluid. Yes, I put this up because all 4 of these are going to make the patient put the patient in a dehydrated state. And this is a common scenario we see in the emergency room. And so the surgeon, a kid who comes in with this history, whether you know it's perforated appendicitis or not, right? Just say the kid comes in like this. We don't know it's perforated appendicitis. What should we do with this patient? Hydrate him. Give him fluids, right? Put an IV in. First thing you do is put an IV in and start running some fluids, correct? Get that perfusion going again. How would you run the fluids? Would you give him maintenance fluids, above maintenance fluids, restrict fluids? Above maintenance fluids, right. We need to give extra fluids because we have maintenance, but plus we have to make up for the fluid losses because of the conditions that the child is suffering from. Okay, above maintenance fluids is correct. How much IV fluids would you prescribe? Okay, all right, there you go, good. So 1.5 maintenance, I love that answer. Would you bolus? Okay, do you know how to bolus? Anybody know how to give a bolus? How much fluid you should give for a bolus? Even if you, I heard it 20, yes. So 10 to 20 mLs per kilogram is what most books will say. The surgeons, we usually err on 20. We don't fool around. Just give them 20 per kilo and see what happens. And then we would use saline or lactated ringers, and we'll talk about in a minute the choices of of fluids. But after we give the fluids, we just don't walk away, right? We have to monitor and see, is this enough? We look at the capillary refill. We look at the heart rate, urine output. See if the patient's mentation is better. Does he have less, if the mucous membrane is now wet, with the skin turgor coming back, right? And this is a continuous thing with our patients in general, particularly with the surgery patients, because they could be annoying when it comes to fluids. They just do what they want. It's hard to anticipate what our kids are going to do. And we talked about the maintenance fluids. I put this here because D5 quarter normal saline with 20 a K is what we would give an infant for maintenance fluids, and then D5 half with 20 a K is what we would give a surgery patient that's, I would say, over 6 months of age. Okay? All right, and that's our bread and butter. That's our water. That's what we like. Okay, let's talk about the differences between saline and lactated ringers. Okay? All right, another busy slide, but I'll take you through this, and this will make sense to you when we're done. I'll have a seat again. Okay, so these numbers should look familiar to you. These are our electrolyte numbers from the plasma, from blood, right? Sodium, 134 to 145. Potassium, 3.4 to 5. Calcium, again, 2.25. Magnesium, chloride, 98 to 108. Bicarbonate, we like to see it between 22 to 32. pH of the blood is 7.4, right? All these numbers look familiar to you. Okay, good. Now let's compare these numbers to what we see in normal saline and lactated ringers. Okay, let's first start with normal saline. Sodium is higher than what we see in plasma, right? So when you give saline, you give a little extra sodium. There's no potassium, no calcium, no magnesium, right? Chloride, also, you give more chloride, right? Okay? No lactate, no bicarbonate, no gluconate. And the pH is usually 5. It says here to 7, but this is usually the saline, normal saline that we use in most hospitals is 5. Is 5 acidic? Pretty acidic, right? So what happens when you give patients lots and lots of saline boluses? They become acidic, and it's a metabolic alkalosis due to all of the anions that are being given. Okay, so let's compare lactated ringers to plasma. Sodium is a little lower, but it's close. There is some potassium now. We have some calcium, which also comes close to what we would want to see in plasma. The chloride is almost dead on with plasma. Lactate. Okay, so what's the lactate do in there? Lactate gets converted to bicarb when we metabolize it. So it's a buffer. So it'll bring up the pH, which it does, from 5.4 to 6.5, and it could be even higher depending on the patient's metabolic activity. 6.5, right, is a lot closer to 7.4 in plasma than it is what you see in saline, which is 5.4. So which seems to be which is the more physiologic fluid? LR. How often do you see people bolus with LR? No. So it's saline, which baffles the surgeons. We're like, why are you giving so much saline? And there are circumstances where saline is indicated, and I'll share that with you too. And I'm speaking now only surgery patients. We're not talking about the patients with renal failure, the patients with other. Now, this is just a surgical thing, okay? Now, this is why lactated ringers is the fluid of choice for patients who are bleeding and trauma. So is LR, right? And the fluid of choice in the operating room. There's also very good studies that show that the potassium and the calcium and the buffering of the fluids helps cardiac function and cellular function. So LR is truly more physiologic than the saline. Okay. Another busy slide, but I'll take it through it. This is a table that shows us the compositions of GI secretions. The chemical constituents are all different depending on what part of the GI tract it's coming from. So in the stomach, our fluid, our volume, and these are adult volumes, can be up to 2 liters. So I guess these would be volumes that you would see in an adolescent. Okay. We have a moderate amount of sodium coming in the stomach. KCl. Okay, so it'd be sodium chloride and potassium chloride. Okay, so potassium and the chloride is higher than both because this is the cumulative chloride content for KCl and NaCl. Okay, no bicarb. Gastric fluids are what? Acidic or basic? Acidic. Yeah, that's okay. Then the small intestines has a lot more secretion of fluid. Sodium's higher, chloride's slightly lower, but look here, lots of bicarb, right? Colon is really, doesn't secrete too much because that's where we absorb fluids, right? We pull back fluids into the body. But in the pancreas, we have a lot more sodium, and the bile, a lot more sodium. There is chloride, but look at the amount of bicarb here, right? So, small intestine, pancreatic, and biliary secretions are what? Alkaline. So we're losing a lot of bicarb as opposed to the stomach where we're losing a lot of hydrogen ions. Okay. So let's look at the child with hypertrophic pyloric stenosis. We have non-bilious projectile emesis, right? Pylorus is closed, just gastric secretions are coming out, as opposed to the patient who has an intestinal obstruction, where small intestinal fluid is coming back up and the patient's vomiting bile. You would expect the characteristics of the two fluids to be different, right? In projectile emesis with pyloric stenosis, you would be losing a lot of gastric acid and KCl. So the patient would be losing sodium, potassium, chloride, and they would get a metabolic alkalosis, right? Because they're losing acid. if you look at if you think about the patient that has all the bilious emesis, they're losing a lot of bicarb, so they might get acidotic. Okay, all right. So in those patients, which one would you give? Okay, so pyloric stenosis, baby, hypokalemic, hypochloremic, metabolic alkalosis. It's a classic scenario that's on all of our boards. Every single board that I've taken, I've been asked that question, even to today in my research. So now let's look. We have a patient who is alkalotic, right? Needs sodium and chloride and potassium. Would you give a patient who's alkalotic fluid that's alkalotic? Right, you have to give him something that's acidotic, correct? Which one is acidotic, saline or lactated ringers? Saline, so good, saline. And we have a lot of sodium, a lot of chloride. So what we do with these infants is we give them boluses of saline, 20 to 40 mLs per kilo until they void it. And then we add the D5 half normal with 20 a K and run them at 1.5 maintenance, and that's where they get their extra potassium. Make sense now? Yay! Okay, let's get the next scenario. Patient with acute gastroenteritis, lots of diarrhea. Okay, what's the pH that's coming out of the poor baby's rear? Is it alkalotic or acidotic?
Acidotic.
Oh, okay, think about it. Pancreas, you have the biliary fluid coming out. You have the pancreatic fluid. Does it have a lot of bicarb? So it's alkalotic. Okay, good. So the patient then loses sodium and chloride, but then gets a metabolic acidosis because they lost all that bicarb. Right? Okay, so what fluid do we want to give? Patient's acidotic now. Lactated saline or lactated ringers? Which one? LR. Right, because you have a patient who's acidotic. You want to give him something with bicarb in it, correct? And then we're still replacing all these other electrolytes that the patient needs. I'm going to stop here. You have any questions? Because this is. I don't think it's not too much, is it? Makes sense. Good. Yeah, does make sense. Okay. Good. All right. So there's a rule that I share with my residents all the time that's helped them. Actually, I share with the medical students, and by the time they're residents, they ought to know this. If you lose fluids, this is a simple rule. If you lose fluids proximal to the pylorus, just give them saline in the beginning, and then you can give them the maintenance fluids afterwards, or maintenance and a half. For fluid loss is distal to the pylorus, LR, because of all the bicarb that's being lost that you want to replace. How's that sound? Easy, right? So if you have a patient with an NG tube that's not draining bile, you can give them saline. But if it's draining bile, right, LR might be good. If you have a patient, let's say, that has enterocutaneous fistula, a pancreatic fistula, right, have pancreatitis, they put a drain in, we're going to give them LR, right? Because they lose all that bicarb, they become acidotic. Okay. So, proximal to pylorus, give saline and then potassium once you know that they have urine output, right? And you don't want to give potassium to a patient that has no urine output because they could have renal dysfunction, right? Like renal injuries. And then fluids lost distal to the pyloric, lactated ringers, right? Because lactate is metabolized to bicarb. Yeah. Okay. All right, so these are the questions we ask ourselves after surgery. Were we able to correct the preoperative fluid deficits? And that's when we have the conversation with the emergency room physicians, or the pediatricians, the hospitalists, and then also with our anesthesiologists. Okay, because now we're ready to write our post-op orders, and we're like, well, what fluid should we give the patient? Were the intraoperative fluids replaced? That's something for the anesthesiologist to determine, and it's all based upon these losses that they can monitor. And then there's the ongoing postoperative fluid losses, which is going to happen in your domain. This is what you will be monitoring and reporting to us and alerting us if there's an issue. All right. So, patients of third space fluid. Why do patients third space fluid? Anybody know? So, due to the injury, whatever the injury is, the insult, it could be the surgery, it could be infection. It could be an inflammatory process. The capillary cells, they become leaky. And fluid comes out from the plasma into the interstitium. And that's why you have the edema. And it's all caused by cytokine release, all these inflammatory markers, right? And there's a reason for it. The body releases these cytokines so that the capillaries can purposefully become leaky so that they can let out the white cells and all of the other things that we need for wound healing, correct? But sometimes that process hurts the patient and the child more than it helps them. So we have to be very careful that if we don't replace the fluids that's being lost out of those leaky capillary membranes, it will hurt the patient. So this is what's really important, that we monitor third space fluid. Bleeding is obvious, right? That's not good. NG tube losses, that's another thing we need to monitor. Chest tube output, and then there's the drains. And we're going to talk about NG tube, chest tubes, drains, and other tubes in the next lecture after I give you a short break. How are we doing for time here? We're fine. NG tube losses sometimes are replaced and sometimes are not, and you probably ask your question, why? In a postoperative patient, usually if a patient has an NG tube, we just go up on the maintenance fluids a little bit. So if a patient has an NG tube, I may put them on 1.25 maintenance, 1.5 maintenance, depending on how much fluid is coming out. But then when it really becomes excessive, then we can replace it. Half cc or cc for cc, okay, depending on the volume or how much I need to catch up to get the patient hydrated. Now I put saline here with 20 of K, but again, remember, if it's really, really dark green, really bilious, I might choose to use lactated ringers for reasons we explained earlier. Oh, good. So I'm up to the summary. Okay, here we go. We have some time to talk about what was just presented to you. Most patients come in with most surgical patients come in with some fluid deficit. It could be mild, moderate, or severe. IV fluid resuscitation is common in a surgical patient and should be sought after immediately, particularly if you see a patient who looks like they've been dehydrated based on history and physical exam. We mentioned that the fluid dynamics in operative patients, post-operative, is changes a lot, right? It's pretty dynamic. We have fluids shifting from one compartment to another and then back to the other, depending on what stage the patient is after surgery. And this is why we have to monitor the patient closely: the capillary refills, the heart rate, the fontanelle, and urine output. And the reason why it's really important to do this is because we need to be a team so that we can give the patient the appropriate fluid responses, appropriate fluid resuscitation, so that the child does not get dehydrated, have poor cellular function, and go into shock. 4-2-1 rule is pretty cool, makes our life a lot easier, correct? And 20 mLs per kilo is the aliquot usually we use for fluid boluses. Now, some may ask, well, how fast should you run it in? Well, it all depends on how dehydrated the patient is. And a severely dehydrated patient, you run it in sometimes wide open, right? Depending on how tachycardic and sick the child is, or it can go in over 30 minutes. An hour is usually the average time that we would give a bolus to a patient in general, but with the surgical patients, we usually like it a little bit faster because we're kind of impatient. We know, we just can see where the fluid's going, and usually those fluid changes are pretty rapid. They're pretty fast. We talked about which fluid to use for gastric losses, proximal, right? Saline. What fluid to use for intestinal losses, distal to the pylorus, LR. And that fluid's the best, LR is the best for replacement of blood loss. Okay, so this is what it looked like yesterday, right? It really rained hard. Any questions or comments that we can add to our fluid management course?